Good afternoon, everyone. So our panel discussion is over now. Now we will proceed to our next session. Our respected chairpersons are Dr. Pallavi Priya, Dr. Rajkumar Krishnasamy, and Dr. Manish Mandal. Now I will hand over the session to our respected chairpersons. Thank you.
Sumeet Shah है ना पहले?
Thank you. I'd like to invite Dr. Sumeet Shah from Delhi for his talk. Sir is an advanced hernia surgeon from Delhi in PSRA hospitals.
Thank you, Pallavi. Thank you, Chairpersons. Thank you, the organizing committee of IASG for giving me this opportunity to speak before you. And the topic that is being given to me is combined mesh repair and open bowel surgery. Is there enough evidence? Now, this is one of the most controversial areas, whether we can use mesh when there is a bowel surgery associated, whether for hernia or whether otherwise. That is one of the most important. So whenever we are faced with this situation, we know that as a surgeon, there are many points to consider. Of course, first is the degree of contamination. How much contaminate? All contamination is not same. A 2 millimeter incision in the small bowel is not same like a colonic tear. What are the hernia characteristics? If it is a very large hernia with a lot of incarcerated bowel, or maybe a small part of the bowel has got incarcerated in a small umbilical hernia. When you have these kind of situations where you have to deal with bowel, and then this question arises in your mind whether I should now suture close it or can I put in a mesh or not. If you want to put in a mesh, what type of mesh you want to put in? And of course, it will also depend whether you are doing an emergency repair or is it a situation which has happened during an elective surgery. If it's an emergency situation, then of course the general patient condition, if the patient is septic and you are doing it in difficult circumstances, of course everybody will want to bail out himself and the patient with the safest possible option, because the priority is to save the patient. Outcomes are very important. There is a saying in Bailey and Love which says that a live problem is better than a dead certificate, right? So that is a very important thing to know in surgery, that we can always come back to deal with it another day, but you should not get yourself in a situation where the outcomes will be poor. However, having said that, we all understand that, there is a lot of fear in putting mesh when there is a concomitant bowel surgery. When could the mesh be contaminated? In many situations, biliary or gynecological, bowel, urology, all could lead to contaminated fields. Enterocutaneous fistula is something that GI surgeons face very often. And sometimes there is an inadvertent enterotomy, right? And it is little ironical that I am speaking about it here, because in 2018 in the HSI annual conference, I was demonstrating a live complex abdominal wall reconstruction. And at the beginning, I had a small patient, had a small bowel enterotomy, which I repaired immediately, and I went on to do a complex repair along with a mesh. And it generated a lot of heat and controversy in the audience, because people got up, stood, fought, and ultimately Dr. Makhan Lal Saha, whose patient it was, and Dr. Beg, who was organizing the meeting, voted in my favor. And we went on to do that abdominal wall reconstruction with mesh. So today I'm here with you to bring to you that what was the evidence at that time that I knew about, which gave me the confidence to do that repair. Of course, there are situations with parastomal hernias, or a strangulated or obstructed bowel during resection, previous infected mesh or infected wound. These are all situations in contamination. So now, once you have this situation, supposing you're doing a large hernia with a complex, bowel involvement, what are the options? Either you close the skin primarily, leave it as it is. Now that is a difficult bailout option, because coming back in these patients with very large hernias is not an easy job if you just close the skin and come out. I would do that only if the situation is life-threatening. Primary closure of the abdominal wall, yes, it is a valid option. If you can close the defect primarily, do a primary closure of the defect and come out. You may not need to put in a mesh. Sometimes there are gunshot wounds or bullet wounds or war injuries in which the surgeons have just left an open abdomen laparoscoma, and then later on we can do some wet dressings, or now this NPWT has come. In between, there was a large group of surgeons, especially in the West, who started using biological mesh, and then the synthetic mesh. And now we have come to the point where there is a delayed absorbable meshes are also available. So since my topic is usage of mesh, I will now focus on use of biologic versus synthetic versus delayed absorbable mesh, right? As the three options. And what is the evidence? Is there enough evidence to use mesh? Now, the usage of mesh in difficult and contaminated or dirty abdominal wounds or laparotomy is not a new thing. Dr. Stone published this in Annals of Surgery in 1981. Where he used, insertion of facial prosthesis. They used to have Prolene and Marlex only at that time. There were no composite meshes, there were no biological meshes. And they used, because they had a lot of patients with gunshot wounds, they had almost 124 patients managed with debridements. Insertion of a facial prosthesis, Prolene in 101 patients and Marlex in 23 patients, right? And they had 25 fistulas, 27 deaths, but these were very difficult situations. And what he said is his experience. He said, number one, insertion of a synthetic prosthesis to bridge any sizable defect in the abdominal wall rather than closure under tension via primarily mobilized flap. Number two, use of end bowel stoma rather than exteriorized loops of bowel. And he said that finally delay in final reconstruction until all intestinal vents or fistulas have been closed, that can also be done. So even in 1981, there was realization that if you are using a polypropylene or a Marlex, as a sort of facial closure device, it can work well. And also Dr. Leif Israelson, whose name all of you know for his small stitch wound closure technique, published in 2012 a 5-year randomized control trial of using a polypropylene mesh for prevention of parastomal hernias. You must remember at that time, today we can talk about using mesh in prevention of parastomal hernias, but at that time, 10 years back, it was like a blasphemy that how can you use a mesh when you are creating a stoma? So, but he did that and he found the results in those patients in whom he had used a mesh was much better than others. And similarly, there were other studies which also used this is a 7-year study of strangulated or incarcerated ventral hernia by Dr. Bessa, which again showed the benefit of the use of mesh. Now, if you look at the prophylactic mesh placement, now this is more recent, this is a prospective multi-center randomized trial. And again, it has shown that, that during an open and elective formation of end colostomy, primary placement of retromuscular lightweight polypropylene mesh for prevention of parastomal hernia is safe and feasible procedure. And I was just talking to one of the busy GI surgeons during lunchtime, and he said that they do a lot of APRs and there is almost 70 to 80% rate of stoma formation. And once you have a parastomal hernia, it's a very difficult problem to treat because no matter what you do, whether you do a laparoscopic sugar baker, whether you do a retromuscular sugar baker, whether you do a slit in the mesh and try to repair it, there is a high recurrence rate, almost 40-50% recurrence rate. So prevention can happen with the placement of the mesh. Now, why are we all so scared? Because, the scare is not just like that. There is this, the article which was published, in Annals of Surgery on use of mesh during ventral hernia repair in clean contaminated and contaminated cases. This was a National Surgical Quality Improvement Program in US. And they looked at the data for 33,000 patients, almost 34,000, and made a recommendation avoiding the use of mesh in any level of contamination, right? This is published in 2012, right? So I want to tell you that the usage of synthetic mesh in contaminated field, although it was there in 1981 when Dr. Stone published it, but as far as hernias was concerned, majorly it was contraindicated even till 2012 when this article in high impact journal was published. Another article published around the same time also said that you should be very careful about using mesh. And in between, because in US the industry pushed the biological mesh saying that it has got many advantages, it can be used in contaminated field, there is less incidence of mesh fistula, you can put it in direct contact with bowel, you can avoid doing a 2-stage repair, and it leads to better wound healing. So this is how biological mesh got sold. Fortunately for India, many of us never had either the availability nor the affordability for the biological mesh. But the industry sold it heavily in the Western countries, in Europe and United States.
As time passed by, the results clearly showed that there was very high recurrence rate with biological mesh to the tune of 40 to 50%, and it did not give any advantage in skin and soft tissue SSIs and SSOs. And that is when Dr. Alfred Carbonell actually was doing a strangulated parastomal hernia in a high-risk lady, and in doing an emergency repair, he put a retromuscular polypropylene mesh. And he said in his talk to us that I got that inspiration after reading that and discussing with Dr. Israelson, who used to already put a mesh, preventive mesh in parastomal hernia. So Dr. Alfred Carbonell did that, and that patient did well. And then he went on to do a study which he published in 2014 saying open mental hernia repairs performed with polypropylene mesh in retrorectus space in clean and clean contaminated. So they had, almost the same surgical site infection occurrence as the biological mesh, but they had a much lower recurrence, only 7 recurrence at a mean follow-up of 10.8 months and 4 mesh removals. So even at that time in 2014, he said, although not yet considered a standard of care in United States, we have demonstrated favorable infection, recurrence and mesh removal, right? So this is 2014 when he, then got his friend Dr. Yuri Novitsky, Dr. Mike Rosen, everybody to get together and to do a larger trial of synthetic mesh versus biological mesh in a clean contaminated situation. And Dr. Novitsky published in 2016 this comparative analysis of biologic versus synthetic, and which clearly concluded that the choice of mesh for clean contaminated ventral hernia remains debatable, but they had demonstrated that the synthetic sublay mesh did much better as far as mesh explantation as well as recurrence was concerned. And they gave many theories on how there is a lesser biofilm formation and more effective clearance, and mesh can be salvaged. Now, this led to the Europeans also looking at the data, and there was this biologic versus synthetic mesh biomesh study group which had almost 20 different leading hernia surgeons from Europe. I've included Professor Cockerling and Dr. Neil Smart, the first and the last author of this paper, as their photographs. And they said that for prevention of parastomal hernias, there is no evidence to support use of biologic or biosynthetic meshes. And in complex abdominal wall hernias, whether they are incarcerated, parastomal, infected, open abdomen, intracutaneous, and component separation techniques, biologic and biosynthetic do not provide a superior alternative to synthetic meshes. So you understand that this journey started with the synthetic meshes. For a time period, the biological meshes took over, and it is only last 5 to 7, 8 years that we have come back from biologic to synthetic meshes, and that is why the evidence is still coming in. Look at this Price randomized trial published in Annals of Surgery in 2021. This is last year. The risk of hernia recurrence was significantly higher for patients undergoing ventral hernia repair with biological mesh compared to synthetic mesh. Of course, that is obvious, but with similar rates of post-operative complications. These data suggest that use of synthetic over biological mesh to repair ventral hernias is effective and can be endorsed. Another trial, because randomized control trials are considered as the gold standard in evidence. So this is Dr. Mike Rosen's group which published this biologic versus synthetic meshes. It's a RCT, large number of patients, considering these are clean and clean contaminated cases, 253 patients. And they underwent, they were randomized to biologic or synthetic meshes, right? And recurrence risk with the biological mesh was 20.5% and synthetic was 5.6%, right? So with an absolute risk reduction of almost 15% with the use of synthetic mesh, and no difference in surgical site occurrence, and of course, 20 times higher cost with the biological mesh without giving any advantage. If there is one message that I want every audience member now to go away with, is that there is no role of biological meshes as of today in clean and clean contaminated cases. Now, outcomes of concomitant mesh placement in intestinal procedures during open ventral hernia. This is also published last year in the Journal of Hernia. Out of 5,104 patients in the mesh group, they were matched 1:1 with and mesh placement, they said, was although associated with some higher morbidity and organ and subcutaneous infection, but long-term recurrence benefits are there. And similarly, a systematic review of surgical site infection in mesh repair for ventral hernia and contaminated field, you can see that all these articles are very, very recent. This was published in 2021. Use of mesh repair in the management of complicated ventral hernia compared to suture repair is not associated with increased incidence of SSI, even in potentially contaminated field. So there are more and more reviews coming up. But finally, I would like to show this article, which again comes from the origin, Dr. Alfred Carbonell, who started using synthetic efficacy of synthetic meshes in the contaminated field. And this looks at 541 contaminated, 245 clean contaminated, and 214 contaminated, 82 dirty cases. So a big number. They did suture repair, biologic mesh, but they used mostly absorbable synthetic mesh, and permanent synthetic mesh was used, mostly permanent synthetic mesh in 402 cases. But the important thing is that all these meshes were placed extraperitoneal, right? So whatever the evidence that we are speaking for so far is for extraperitoneal mesh placement, not for intraperitoneal. So you can see that they had excellent results. With this kind of 541 contaminated cases, they had only 7 mesh removals. And of course, at a median follow-up of 30.2 months, recurrence occurred in 15% of the patient, and this was significantly lower with the permanent synthetic mesh. And this is how they showed it in their figure. So they showed the permanent synthetic mesh is safe in contaminated ventral hernia. It has got the lowest risk of recurrence, equivalent risk of skin and soft tissue infections, and equivalent risk of mesh removal. Therefore, as of today in 2022, we can say that the permanent synthetic mesh placement in extraperitoneal position and the kind of the mesh that you place is a polypropylene medium weight macroporous mesh. I did not want to bore you with all the details of the mesh related evidence that how did we come to this conclusion that you should place a polypropylene over a polyester, how you should choose the porosity of the mesh, and how you should choose the weight, because that is lot of basic science evidence. So I did not want to go into that, but just I want to conclude by saying that as of today we have got enough evidence to say that in clean and clean contaminated repairs you can safely put in a mesh. Having said that, the last thing I want to say is that it is every surgeon who has to make the judgment on the table, regarding his patient's condition, regarding your risk-taking appetite, and regarding the safety and your own comfort of doing these similar procedures in elective situation. If somebody has not done a retromuscular repair in an elective situation, one should not embark on it in an emergency situation. Of course, it makes sense, right? So each surgeon is the best judge of what he wants to do. But this presentation was just to take the fear out of the mind that there is no way that you can use a synthetic mesh in a clean contaminated or contaminated field. You can use it, provided you use the right mesh in the right plane under the right conditions. Okay, thank you.
Thank you, Dr. Shah. We have time for one question from the floor if anyone wants to discuss something. Okay, so we'll move on to...
Thank you so much.
Thank you, Dr. Shah.